Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we begin, just want to go over a few items with you all. Please be aware that this session is being recorded for educational purposes. If you're interested in viewing the recording, feel free to visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, feel free to use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only the Blum Center staff and the guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Okay, Aswita, would you like to pull up your slides? So next, I would like to introduce you all to Aswita Tan-McGrory. In her role as director at the Disparities Solutions Center, Aswita leads the center's portfolio of projects focused on addressing racial and ethnic disparities in healthcare. She also travels across the country to speak to organizations about how race, ethnicity, and language impact the quality of care. Aswita serves on several executive committees, including the MGH Executive Committee on Diversity and Equity and the Partners Health Equity and Quality Committee. In addition, she sits on the board of the Massachusetts Public Health Association and is adjunct faculty at Northeastern University. Aswita currently serves on the Massachusetts Executive Office of Health and Human Services Quality Measurement Alignment Task Force. As Administrative Director of the Mongan Institute, Aswita works in tandem with the director to provide overall strategic and operational responsibility for Mongan Institute staff, programs, expansion, and execution of its mission. In addition, she works with the Mongan Institute unit leadership to facilitate interdisciplinary teamwork, manage and improve operations, provide data and decision support, manage team initiatives and projects, and provide oversight for strategic initiatives as the Institute moves forward under the direction of the Mongan Institute director. The Mongan Institute in the Department of Medicine at Mass General Hospital is dedicated to supporting research across MGH in the areas of population health care delivery science. In recognition of National Minority Health Month, Aswita joins us today to give a presentation on what we learned from COVID-19 about making healthcare systems more equitable. So please join me in welcoming Aswita.
Thank you, Amy. I should have told you not to read the whole bio. It's such a mouthful. I'm really sorry. And it looks like we have a really nice small group, and the benefits of that is we can have more of a discussion. So I would encourage everybody listening in, and I saw some familiar faces, so that was really nice to make sure that you ask questions in the chat that can allow us to have like a really good dialogue. All right, let's do this. So I just put this definition on, since this is sort of more of a public facing webinar, and it's really a definition on what are disparities. And for our Disparity Solutions Center, when we think about disparities, we're really looking at gaps in the quality of care that we provide to our patients due to differences in race, ethnicity, socioeconomic status, sexual orientation, gender identity, and/or ability. And so a lot of times when I talk with my friends and family about what I do, I give them an example of a sort of an older study that looked at when patients come into the emergency room with a broken arm or a broken leg. Black patients and Latinx patients were less likely to get pain medication, even though they had like the same socioeconomic status and the same insurance. And so this is always a sort of a moment where all my friends and family go, what are you talking about? And it's like, yeah, it's interesting that it's still a surprise to people. But this is clearly a problem in our healthcare system, that we are providing different levels of care. And so, we are looking to uncover what are the root causes of that. And it's sort of multifactorial. There isn't a simple solution, unfortunately. This is a really complex problem. And what I have here on the screen are two reports that are sort of the foundation of the work that we do at the Disparity Solutions Center. So one is the unequal treatment report from the Institute of Medicine. And this was put out in 2002, and actually the founder of the Disparity Solution Center, and he's now also the Senior Vice President of Equity and Community Health, Dr. Joseph Betancourt, he was on this committee. And this committee really looked at all the data and said, you know, disparities exist, racial and ethnic disparities exist. There's multiple root causes. It's not one thing. And they made some recommendations. Now, the second report that you see here is really called Crossing the Quality Chasm, also put out by the IOM. And this talks about sort of the 6 pillars of quality. And I'm not going to embarrass myself by naming all 6. I think I do know them, but just in case I don't, but equity is one pillar. And the thing is that equity probably overlays all 6 pillars if we're going to be honest. So I think patient-centered care is one, timeliness, efficiency, effectiveness. So all of those are pillars that are considered, you know, providing quality care, and equity is one of the pillars, but honestly, it can overlap all 6 pillars. So combined, this is a foundation of when we think about racial and ethnic disparities in healthcare. These are the 2 reports that sort of set the path of what we should be doing. And so that report, the IOM report, came out in 2002. And if you're asking me like, well, how did we do? So since 2002, I mean, we're in 2021 this year, not so great. So this is the National Healthcare Disparities Report. And really all you need to know when you look at this graph is the blue bar says there's been no change in disparities. So we really haven't been able to move the needle very much. Incrementally, you know, we have improved some of the disparities. There has been some worsening, but overall, not much change. And so the question that we always have to ask ourselves, why? And I think, you know, in the current year, we know a lot more. We have had a lot more dialogue about racism, bias, structural racism, our history, all the things that contribute to these disparities. But there's a lot of work to be done, and it's a really complex topic, and it's also a difficult topic to talk about. And I just want to share a screenshot of our homepage, our website, which, you know, is available, and we put a lot of our resources and guides that we develop over the course of, this is our 16th year that we've been around on this website, and you'll see including in that is a COVID-19 header where we really highlighted a lot of the work that we did around COVID-19 and equity work. And so I would invite you to take a look at that. The other thing that we've really learned a lot in our center is by working with other healthcare organizations. So not only do we focus on the work here at Mass General and to a certain extent at Mass General Brigham, but we've also been through our Disparities Leadership Program able to have other healthcare organizations work with us on addressing racial and ethnic disparities. And this is very helpful because it allows us to really understand like what is happening on other parts of the country and share sort of best practices, but also identify like how are the challenges maybe different in the South or in the West or in Canada. And so organizations join our program for a year, and we help them advance a strategic plan or a project focused on disparities. And this will give you a quick snapshot of where folks have come from. As you can see, we need to make some progress in the middle here, but the blue is all the states where we've had alumni come from and join our program. Hawaii is my favorite, but we also have Puerto Rico and Switzerland and Canada. And so even when we are internationally and the populations may look different, the challenges are still the same, right? So what I thought might be helpful and is a little bit more universal is thinking about, you know, what did we really learn from the last year that we have been in COVID about equity and our healthcare system. And part of the reason that this is such a a great topic for everyone is because we are still living it and because we're all affected. And I think unlike some of the other diseases where it might be a segment of the population is affected, or a area of the country is affected, or a part of the city, this is something that if we don't figure this out for all of us, it will continue to be an issue. And so there's relevance here that's very universal. And it has sort of pulled the wool from everybody's eyes about what are some of the challenges in making sure that our health systems are equitable and knowing that they're not. And I think so one of the first lessons, as you remember, in April, I was telling a group this yesterday, who is not from Massachusetts, but I still very clearly remember last year at this time when we were going through the surge and how that felt and how the shelves were bare of like any supplies. And I was talking to a friend of mine about how like we were just sort of scrambling to buy pasta, even though like my house is not a big pasta house, but just the urgency that we felt, and coming into the hospital during the surge and going to the COVID floors and how there was like no traffic on the roads, and also the just unknown and the fact that we couldn't get PPE and it was so hard to get like hand sanitizer solutions and all of these issues that only just happened a year ago. But the biggest thing that I would take away is when I started working on thinking of making sure that our COVID strategies thought about equity, is that lived experience should really guide change. And what I mean by that is that when I started working with a lot of teams across our healthcare system, we were all going on Zoom probably for, the majority of our meetings for the very first time. And the nice thing about Zoom is that you can visually see everybody at one time. But it also made me realize that what was coming and looking back at me were mostly white folks. And that I realized that when I was talking to them about racial and ethnic disparities, I had to do some preamble on like why it was important that we think about equity when we thought about COVID mitigation strategies. And so I just think that like one of the takeaways is that these systems are designed by people who may not have lived experience, and that's why they only work for a certain segment of the population. And I will just get into that a little further down the line. But one of the things that people always tell me is that the challenge of hiring diverse staff, physicians, is there's no pipeline, there's a limited pipeline. And last summer, we were asked to put together a COVID Corps internship program because many internships were being canceled. And this was a 100% remote internship. And we were asked to put it together in very short order. So I think in the space of like 3 weeks, which is like impossible. But we made it happen. And one thing we did is we made a deliberate commitment to make sure that this was a very diverse program. And this is the result, is that the top 2 rows are all the interns, we actually had to shut down the application after 6 days early because we got so many applications. We got over like 300 applications for 22 slots. And if you see this, I always say a picture tells 1,000 words, and you see how wonderfully diverse the group of students are that we were able to get. And this is about being very deliberate about and intentional about you wanting to hire diverse practice and communicating that to the applicants, right? And so when people tell me, well, the pipeline is a problem, I was like, no, it's not really a pipeline. It's that you're not being deliberate. Look what we can do. And especially at Mass General Hospital, we're a stellar organization. We should be able to draw this talent. And so I think it's really important that when we design these systems for our patients who experience poverty, who aren't health literate, who aren't technology savvy, who don't speak English, who don't have the resources that the rest of us may have, it is important that people who are designing the system can speak from that perspective, because otherwise we end up with some of the systems that we currently have, which is they work for some, but they don't work for others. And that's a problem. The other lesson that we really learned is like, you need to take the steps required to build community trust. And so here is a picture of the Boston Hope Center, and we all know that. We went to visit it during the surge when they set it up. And, you know, it was in a convention center, and it really was meant for COVID patients who were being discharged and they didn't have a place to sort of self-isolate when they recovered last year. And this would be a place where they could get that and get medical care at the same time. And we thought this was great. We collaborated with the state. It was like an immense effort to put this together. But for the most part, it was mostly, you know, half empty. And part of what we learned is that, you know, we didn't do we did a great job putting it together. What we probably didn't do a great job is talking to the community and letting them know like what this was for. So there were a lot of rumors in the community about what this was. And one of the things was that it was staffed by military personnel. So when you walked in the door, there were folks in military outfits there at the door. And you can imagine for any immigrant, there might be a fear of being in a place where there's police. Any undocumented or even documented immigrants, to be honest, would have that fear. So the word around the community was like, don't go there. And if you then overlay that with the fact that at some point in time, over 50% of the patients were coming from immigrant communities like Chelsea, Revere, Lynn, Everett, you know, it shapes a different picture, and they're living in intergenerational households where they couldn't, you know, self-isolate. So community trust is important, and we need to spend more time building that and working with the community to message like what this is and to address any concerns. So that was one lesson that we learned. And community trust is also that is based on historical events that preceded us, right? So we have to acknowledge things that happened in the past and understand how that impacts the trust that a community currently has. The other lesson, what we learned is we really need to spend some time in addressing language barriers. A lot of our patients, so it's very different if you're a medical staff on the floor and only one or two of your patients need an interpreter. During the surge, like half of your floor needed interpreters. And all of a sudden, people were realizing the importance of having an interpreter at every interaction and how our system wasn't clearly working. I mean, we were challenged with the shortage of PPE, so you couldn't bring interpreters into the room, right? We were trying to preserve PPE at that time. But also, so then how do you have an interpreter join, you know, a visit on the floors? How do you have an interpreter join virtual visits, which happened because we shut down our ambulatory care? And as we know from the research that for patients with limited English proficiency, they're more likely to have adverse events. And when I say adverse events, I mean things that shouldn't happen. So falls are adverse events, or surgery on the wrong hand. And they're more likely to experience medical errors, and they're more likely to experience physical harm. And probably most of it has to do with communication, right? So a lack of ability to be able to communicate. And then what you see here is just a data snapshot. When we looked at like the number of interpretations that we did, what you see in the bottom line here is the number of video interpretations, right? So it went up slightly in April during the surge. And then the second line from the bottom is face-to-face interpretation, which is really the preferred modality for many folks, clinicians and patients. And that dropped once we, you know, closed a lot of our ambulatory care. What you would then expect is, okay, so if we were switching to virtual care, the number of video interpretations should go up, but it didn't really go up. What did go up is phone interpretation. And that's because our system really couldn't accommodate interpreters into our visits, onto our floors. We had to figure out like how to fix that in real time. And phone, you know, interpretation and phone visits is not ideal. It's better than nothing. But, you know, when you have an interpreter in a room, it's good for them to be able to see the patient's faces. And it also provides a higher quality of a visit. And so there were a lot of things that sort of worked against us, not including like broadband access, technology access, you know, digital literacy, so the ability of a patient to navigate. And while virtual visits were great for some, they were really creating more disparities for other populations. And it's interesting because it's always touted as like a great solution, like our, you know, digital apps are touted as a great solution. But that's because who designs it is really savvy with the apps, right? They're not thinking about like if a patient, you know, only has a certain number of visits or number of minutes on their phone, the virtual visit's going to wipe out all of their minutes for that month. Then what happens, right? Thinking about things like that. So we did a lot of work around that. And then understanding that social determinants of health still impact 80% of COVID-19 health outcomes. So this doesn't go away, right? And in fact, it was key to us thinking about mitigation strategies and even vaccination strategies. As you see here, this graph that we've seen before is that 20% of clinical care contribute to health outcomes, and everything else is really around social determinants of health. And so, you know, what I mean by that is like thinking about intergenerational households, poverty. Somebody like me could work from home, but there were essential workers during the surge who had low-income jobs, who were working in grocery stores, who could not self-isolate, right? They had a job that they had to go, not self-isolate, they couldn't work from home. And so access to running water and health food. So if you think about American Indian reservations and how COVID has impacted them and the inability to have running water and health food, access to masks, hand sanitizer, cleaning wipes. There was a huge effort at the Mass General Brigham level to bring this masks and hand sanitizers to communities of Chelsea, Mattapan, because they were so limited in supply, right? I mean, I remember planning my trips to Target around like when I knew I could get my hands on like a bottle of wipes or a hand sanitizer. I mean, we're so resilient that we can forget things very quickly. But I like to remind myself of how that felt at this time last year. It was not a great feeling. And then access to broadband and technology. You know, I can work from home because I have great Wi-Fi. I live in Somerville, has a good infrastructure. But in Chelsea, a lot of the students couldn't do remote learning because they have very limited towers. And so it's not even a fact of like, did you get Wi-Fi in your home? It's even if you had Wi-Fi, it's not great because the infrastructure doesn't support it, right? And that's a really big problem that I just found very interesting that even if you give people the technology and the Wi-Fi, you know, depending on where they live in the neighborhood, it might not support it. The other lesson that we sort of learned is thinking that you really need to use racial and ethnic language data to focus on mitigation efforts. So what you see here, and I saw some of my colleagues on the line today, is our partnership with the Center for Quality and Safety. We've looked at our outcomes and quality measures for over a decade and have looked for disparities to make sure that, you know, we are tracking those. So we stratify and look at all of our quality metrics by race, ethnicity, and language, and other and other factors to see if we have disparities, and then think about what we can do. And most of it involves like us partnering with colleagues, listening to our patients to find out like what are they experiencing, and then also monitoring sort of like post-intervention and sharing these findings. But we had this foundation pre-COVID, and it really allowed us to take that and pivot very quickly and build a dashboard with the help of my colleagues at CQS to build a dashboard that could stratify and look at who was on our floors and in our hospital and where they were coming from. And so this is how we knew in short order that we needed to focus on interpretation efforts, because we had a lot of patients that need interpreters, and we could see the neighborhoods where they were coming from. As you can see here on the map, you see the top 20 cities and towns: Chelsea, Boston, Revere, East Boston, Everett, Lynn, Malden. These are all towns with a high number of immigrant populations, very dense towns, limited resources, and that's where the patients were coming from. And so, this is key to understanding. And I will say at the state level and even at the city level, they did not have this kind of data. Because in order to have this kind of data, you have to have the foundation to build, to build upon. So it was really, really great. And it really highlighted that we needed to continue our efforts in collecting this data. Now, having said that, I always like to make a caveat that we have a lot of data for white, Black, and Latinx populations, but not a lot of great data for Asian American, Pacific Islanders, or Native American populations, just in general. So I'm not speaking specifically around Mass General. And that's usually due to sample size, data collection errors, and a host of other things. But why I like to raise this is because without data, there's no action. And so while we've made a lot of traction in understanding what some of the disparities are for Black and Latinx population, there is so much heterogeneity in the Asian population, and they've all been lumped together. And then I think the data collection efforts haven't been great at a national level, that we don't have a good understanding of what Asians face as disparities. And I think we've seen this a lot in the last couple of months with the killings in Atlanta to start, and then just the general backlash towards Asians, and that's a whole other webinar, which I did do and is recorded, but I just wanted to raise that. And then for the same token, Native American populations, there's a real lack of data on their disparities, and what it allows us to do is to just not do anything, right? As the first thing people will say to you is, show me the data and show me that there's a problem. And I think this might be the last one, is the other lesson that we learned is really addressing privacy concerns and immigration concerns. So we heard from folks that immigrant patients were really reluctant to join virtual visits. They were reluctant to download Zoom. They were reluctant to use the patient portal, which is called Patient Gateway. And that part of the reason for that was because they were worried about downloading things on their phone, but also what information that would collect, what we would share with ICE or immigration. And to be honest, it's a solid fear, right? Think about your own phone right now and what information it collects just without you even touching it. I see ads popping up on my social media accounts because somebody today mentioned some product, right? And you're like, wait, how did I get on this? And it's because Siri is always listening. So I think it is not an unfounded fear. But one thing we realized is that we had actually not sort of addressed this fear and had written some script that was approved by the legal department that said, here's what we would share and here's what we won't share. And so I think that's the first step. It seems like a very simple step, but we sometimes tend to forget the really simple steps that address this. So this was something that we implemented to encourage, to give people a tool that they could discuss with patients about their fears and legitimately say, okay, well, we won't share this information unless there's a warrant or a court order. And then the other thing we do is patient education, which I know the Blum Center is a big fan of. And actually we worked with the Blum Center, to be honest, on the script. But patient education is another key thing. And what you see here is these cards that we can distribute to patients in different language that really says, what are your rights under the US Constitution? I mean, that's important for patients to know. There's other things I didn't list on here that we can do, which is, what do you document in your medical record about an immigration status? And the answer is you shouldn't document anything because you never know when somebody will need to take a look at the record. But making sure that clinicians understand there's different ways that you can document that without actually documenting that somebody's an immigrant. And so we had to really think about these privacy concerns that our patients had, which was stopping them from participating in virtual care, but also, accessing, for example, if you think about accessing vaccines, and getting access to that, which in our system would be through patient gateway. We had to really think about the systems that may not be working for everyone in that way. And so that's really some of the basic lessons in a nutshell, big overview. This is a big topic, and I mean, we could turn this into like an entire conference. So I thought this is a good distillation, and then here's my contact information. So I'll just stop sharing. Wow, I did 30 minutes on the dot.
Thank you so much, Aswita. So we have approached toward the end of the session. If you have any questions for Aswita, please feel free to enter them in the chat box. So we have a question from an audience member. Could you say a word about the use of trusted messengers and how MGH used them to encourage getting care as well as getting vaccinated?
Yes, thanks, Stephanie. So I will just say that, trusted messenger is tricky because there's who we at Mass General think should be a trusted messenger, and then there's who the community thinks is a trusted messenger. And actually, I think the terminology, we got some feedback that we shouldn't use the word trusted messenger. I can't remember what the terminology was, but it was more like community partner, right? Or something like that, because we make these assumptions about who we think trusted messengers are without actually checking with the community if they are. But we used them in several ways. I think one way that we did is when we came to getting patients, encouraging them to get vaccinated. One thing we did is in the immigrant communities, we had folks who spoke their language, who looked like them, talk about some of the information about vaccinations. And I think this was a really successful campaign in getting at some people's hesitancy about the vaccine, and hearing it in a language that they understood, right? And videos were a really great tool that we used. I will just say that we have to be careful that we don't use these communities' hesitancy about vaccines as a way to sort of not address the fact that the systems we build to sign up for vaccines are wacko and difficult to access. And I just say this because I tried to sign up a friend of my husband's, actually a work colleague, because he just wasn't he was in construction. He has one step up from a flip phone, and he's just not savvy. So I said, I'll sign you up for an appointment. And he had one medical condition that would qualify him before it opened up to everybody else. I spent 6 hours on my phone refreshing. First of all, I had to figure out wait, this isn't easy. And then I read on Facebook that there's all these shortcuts. And then I started talking to my friends, and they're like, yeah, if you do this, you can bypass that, right? And it was just so fascinating to me that I spent 6 hours getting him an appointment. I was on the Walgreens website, basically hitting refresh. And I was like, nobody would want to do this. And at 1 a.m., I got an appointment. And then I find out that 1 to 3 a.m. is the golden time when you can get an appointment. I mean, that's so crazy. So we are not, as a system, acknowledging that, yes, there's vaccine hesitancy, but there's also these systems that we're asking people to, go online for multiple hours, and it's just this crazy system. And then I was just like, you're going to take whatever appointment I get you. So you're gonna have to take time off work. And if it doesn't work for you, I'm sorry, but like, I'm not spending another 6 hours, right? And luckily, well, he got the Johnson shot, because I was like, thank God, he lets do one appointment. This is before everything came out about Johnson. But I guess my word here is that we oftentimes sort of, while vaccine hesitancy is true, that is not the only reason why we saw low vaccination rates in these populations, right? And I did try the phone, and the operator basically had access to the same system, but wasn't willing to spend 6 hours refreshing for an appointment. So, it just doesn't work. And I think we see that in other parts of the country, that that's creating some challenges. So trusted messengers are important, but I think examining our systems and what we are building is another thing that we need to make sure that we do. That was a really long answer.
Can you speak on a Mass General Brigham level? Have we done anything to make it more accessible, easier for people to book appointments if they are a patient at Mass General Brigham?
I think the challenge is that, and I spoke to Joe Betancourt about that yesterday, that we have a limited supply of vaccines, but it is smaller than our actual number of patients. I mean, we have thousands and thousands of patients, and I think we only had like 14,000 vaccines at one time. So I think the challenge is in trying to roll this out. And then I would just say that most folks have found it easier to actually go into the community and get their shot. So I think Mass General Brigham is doing a lot and has expended a lot of effort. And I think their probably best efforts are when they go into the community, right? Versus like trying to have patients come to us through Patient Gateway, but it's when they like bring vans into the community like they've been doing. And I think they've gotten very creative in using like some of these vans that weren't being used because of the pandemic, and sort of repurposing them to go into the community and bring messages about COVID mitigation strategies. And then they've used vans as a way to also, I think, do some of the vaccination education. And so I think getting more creative and thinking outside the box is definitely the way to go.
Mm-hmm. And you showed a slide about the rent cards. Can you explain a little bit more about them and how they're given, distributed to patients?
Well, so this is part of the challenge, right? Is that we're mostly in an online world, right? In a virtual world. There aren't a lot of patients coming on site. But in an ideal world, it would be, pre-pandemic, it would be like you have these cards in like the waiting room and you leave them out for patients. But also, I think we need to do a little bit more work in this, is like give them to patients as well, who we think would need them. I think this is an area where we could probably do more work about how do we meet the needs of undocumented immigrants who are really fearful of anything and rarely come onto our sites for care. And when they do, it's very stressful for them because there's so many unknowns. And there have been cases where patients have been picked up by ICE, nationally or even locally. And so those stories make the rounds in the community, and they're very powerful. So even though we say like, it's safe, you should come here, like I don't, again, it goes back to this trust that you have with the community. Will they trust what you say? And the trust is based on historically, what has your relationship been with this community, which means have you shown up? Have you, invested in the community? Have you listened to the community? Have you asked for things but not given things back? So, these are all things that contribute to that.
Would you be able to provide some specific examples? I know you talked about caravans and touched upon community messengers. Would you be able to provide some examples of what efforts have been going on in the communities?
A lot. I mean, I will just say I'm very proud of Mass General Brigham and MGH's relationship with the community, and having really like invested in it, and whether that's through programs or to really go to meet the patient. So a lot of door-to-door efforts that have happened during COVID, recognizing that we needed to work with community partners. So thinking about like sites in the community that aren't used. Like in Somerville, I go to Target a lot. And there's a fancy building next door to it that actually Cambridge Health Alliance is now using for what looks to be a vaccination site, right? And having similar sites like that in the communities of Chelsea. And I think this is why it was very disappointing. If you think about that map I showed you, it was very disappointing when the state put out the mass vaccination sites that they weren't located in the communities that really needed them. They're like, no, I think they were located in Newton, like out in the suburbs. And it's like, well, did you not look at our map? Mm-hmm. And so again, this is this is not a structural barrier, right? That we are creating for patients. Like, they have to go all the way to, and I think, there's been a lot of work done to address that, but like in the very beginning, like when we saw that, we were just like, wait, what is happening?
Great. So I'll give it another minute to see if anyone else has any questions in the chat box. In the meantime, do you have any other thoughts you'd like to share with the audience?
About
like any work going forward, any visions?
I would just say that, like, I have this poster board behind me. I reference this a lot. I use this for when we did the kneel-in event at Mass General last summer, and I wrote on here, do the right thing, get uncomfortable, be anti-racist. And so my number one advice to people when they're feeling a little overwhelmed with all the information and they feel like, it's so much, is, well, let's just get comfortable being uncomfortable. We're going to talk, this requires us to really take some deeper looks at our country, our own role in this. And it's a continuous sort of learning path. I mean, I feel like I'm still learning a lot. I've learned a lot in the last year, and I've been doing this for more than a decade. And then I watched Zootopia. You'll appreciate this, Amy. I watched Zootopia with my kids, which includes a teenager, and it's a really great story. And I love the story if you've not watched it, because it's about like the bias that we have against predators. And so the whole story is kind of very much an analogy, and my 15-year-old picked up on it. She's like, this is kind of about racism. I was like, yeah. And like, how that sort of impedes us all working together in the Zootopia ideal. And at the very end of the movie, the little rabbit, I can't remember her name, she says to the fox, who's a predator, she's like, it's going to require me changing and you changing and all of us changing to create Zootopia. So I would just say our Zootopia of equity is exactly that. Like, I have to change, you have to change, we all have to change in order for us to get to this utopia of equity that we think about. So I just always like to draw analogies like that.
I'll have to add that to my watch list.
It's a great movie.
So we do have a couple of questions. Can you touch on what individuals can do to gain more participation from groups that are so often not represented, more specifically on the research side?
Yeah, it's a good question. And actually, I think, again, the elements are the same, right? It's about trust and about showing up. And the people that I've seen be most successful in doing research in the community showed up and listened to community needs that didn't necessarily align what they had identified in the research of what they wanted to focus on, right? But they listened to the community and were able to provide them with whatever it was that the community identified as a need. And then that allowed them an entryway into also like doing research with participants. Now, this is tricky as a PI. I also wear the administrative director hat as a from the Mongan Institute. And so it is tricky as a PI. Well, okay, how do I do that? And I do think like probably the successful researchers are in the community, they're talking, they're doing things like going to where the community members are. They are answering questions about whatever the community has questions about. And so it may not be about your research study, right? It may be about COVID, it may be about vaccines, but you're there as a resources, and that's how you start building that. Now that sounds like a lot of work, and yeah, it is. It is, because you have to overcome like the years of historical sort of things that we've done to immigrant populations, populations of color. We've taken things from them. We've done research on them without their consent. There's so many examples, and so yeah, you have to overcome that. And then I think around patients who don't speak English, I think one of the reasons that we know that it sort of falls apart is because we probably don't, need to support researchers better in thinking about from the design perspective, like how do I design my grant so that I have like the right amount of funding for translation, that I'm realistic and the timelines that it takes. Like if you aren't partnering with somebody, for example, from the interpreter department to like put that together in your grant, it's gonna fall apart in the details. So I would just say that, credibility matters. And if you don't have credibility with a community and you just show up and expect them to sign up for your research trial, you have to take a look at that. Like how do I build credibility?
And how have we been gathering data in the communities?
Well, again, it's community partners. I think the best thing you can do is partner with like a community-based organization that has that relationship of trust with whatever group that you're trying to reach out to, and ask them like, okay, so what do they need? And creative things like, I know that I had read somewhere that like one research group provided like daycare vouchers, right, for their research participants. I don't know. You just have to think about like, take off your research hat and put on your community hat, and then try to see how I do it. I will just say it's still a continuous challenge because Henrietta lacks Tuskegee, but like the surgery that we did on sterilization. I mean, there's so many things. So research has a difficult job in trying to get into community, but it takes time. And the problem is that your research project never has any time. So you need to actually do this before you start writing the grant. And if you can't, then you need to partner with somebody and not be so obvious about what you want and what you're going to take from them. It should be a two-way relationship.
So working closely with your key stakeholders, including community leaders.
Community leaders, but I mean, it has to be obvious that there's a mutual beneficial reason. I think sometimes we don't see it that way, and we don't listen a lot, and then also we don't have time. The other thing is that a lot of times, and I've heard this a lot, when research is done in communities, researchers don't come back and share the results with the community, right? That's key, really, for any group. When you ask them to do something, you need to come back and show them the results and what you did with it, and impact change and get their input. And so that step is oftentimes missing in the research piece.
Do you have another question in the chat? Early in the presentation, you mentioned disparities with pain medication distribution between white and Black/brown patients. Additionally, we've all seen discouraging disparities data and other treatment differences. These disparities got me thinking. Since we are teaching hospitals of Harvard Medical School and have both nursing and physician training teaching opportunities, are there plans to add disparities in healthcare for similar programs to any curriculums?
I think don't quote me on this because I'm not in graduate medical education, but I do think they already have a component in there, right? I think the challenge is like you can teach it in medical school or nursing school, and then the rubber hits the road, meaning they go into clinic. And so what happens, and we heard this a lot in some of the projects we did, if your attending doesn't think that having an interpreter at a visit is important, they don't want to wait. right? Like, and you're only like a medical student or a resident. There's a power dynamic there. So I think while education is important, and definitely this new generation of docs and nurses have been pretty vocal about the importance of like Black Lives Matters, and I think that's really great. We do have to acknowledge that like our leadership is mostly white, and probably not thinking about this at the forefront. So like if you're in a resident and you know what should be done, like that's the struggle, right? So we really also need to influence from the top down, not just like the incoming generation, but it's a good point.
All right, so I think that's all the questions that we have for today. I mean, I think we could probably end a few minutes early. Aswita, thank you so much for a wonderful presentation. Everyone, thank you so much for joining us. As mentioned, the program recording will be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone, and have a lovely rest of the day.
Thank you.